Good day, ladies and gentlemen. This is O.P. Yadav, and today we have pleasure in having Dr. Satyendra Tewari, who is the Professor of Cardiology at the SGPGI, Lucknow, and a very renowned name in the field of interventions. And we are on the sidelines of the first World Congress on Cardiometabolic Disorders. Welcome, Dr. Tewari.
Good morning. Welcome.
Dr. Tewari, you have been spearheading the radial artery interventions. So can I ask you a very basic question? Why femoral artery is yielded grounds to the radial artery as an access for coronary interventions?
Yeah, that's a very good question, and it concerns everybody, all the interventionists. See, still the femoral artery route is gold standard, and the only two reasons being it becomes more familiar, easy to learn, and easy technique to do not only the coronary but peripherals as well. So in most of the places world over, we started with the femoral, and still it is a gold standard. But now for last 1.5 decades, people are shifting into the radial approach because it is more convenient to the patients, and mobilization is early, the hospital stays become less. There is no doubt that it is technically more difficult, it has a longer learning curve for the interventional cardiologist.
So is it these soft benefits only, or is there any other advantage technical of shorter distance to the heart or some such thing?
Doing a femoral approach world over, it has some basics problems like femoral complications, groin complications, hematomas, some major bleeding concerns, then formation of fistula during the puncture, and then retroperitoneal hematomas in some cases being reported. So it still has a concern. So while shifting over to the radial, which was started way back in '88, and then over last 1 decade it has really picked up, and most of the coronaries PCI can be done through the radial approach unless you are using intra-aortic balloon pump or temporary pacing. Definitely in those situations one can prefer a femoral approach.
Now, once you have used the radial artery, I'm a cardiac surgeon. Yes. May I ask you, can this conduit be used for a bypass surgery, or you would recommend that cooling off phase should be there?
Yeah, a radial approach, while doing radial approach, we try to do a dominant hand. So if a person is a right-hander, we try to do with the right radial because it is convenient for the operator. Number two, as you rightly said, that as a surgeon, usually the left radial being used as a conduit. So if one is comfortable with the right, then definitely left is not the concern for us.
Okay. And is there any special hardware that you use when you do a radial intervention as compared to the femoral?
Oh yes, when it was started way back almost 2 decades back, the longer sheets of 6 French or 7th French were used, but now as a more and more technical advances being has higher, it makes sense that we use now 4 French, 5 French sheets for diagnostics, and even with the intervention PCIs, we use 5 French sheets, and there are guiding catheters by which we can, in the same guiding catheters, one can use the left coronary's intervention as well as right coronary intervention in the same go.
So now when you use such smaller sheath, is the incidence of bleeding and the pressure that you apply on the side, does that get reduced?
Oh yes, that's a big advantage. There are 3 major trials, REVEL trials and STEMI trials, where they have neck to neck compared with the femoral approach, and they see that the since it's The radial approach is much more easier because of the bony prominence. It's easier to practice. The learning curves become easier as you do 50 or 100 cases. And then the hematoma formation is less. So it's pretty safe, and there is early mobilization as well. So it is very convenient for the patients, though technically difficult.
So can it be done as a day case procedure than angiography?
Yeah, we at our centers, we do almost 90% diagnostics with the the radial artery approach. And the diagnostic, for the diagnostic procedures, patients come as a OPD procedure, come in the morning and then go back in the evening. But if they need a PCI, then definitely we want to hold them back for a night or so.
And what is the follow-up protocol for these patients, right, starting from the puncture and the patient is shifted from the cath lab?
Yeah, we have actually radial lounge. In that, patient is sitting, he can eat after the procedure, he can directly walk into his room, and there he can do his normal, he can watch TV, he can write, he can eat, and by the late evening he can go back because there is hardly any hematomas or some bleeding, unless patients develop some perforation in the arm, which we do rarely see, because it can happen because more and more GP2 inhibitors being used for acute MI situation. Then sometimes we hold the patients for a day or two. Otherwise, most of the patients' diagnostic procedures, they can go home the same evening, or if they require a PCI, it is uncomplicated, they can go next morning.
And before you choose a patient, do you do Allen's test and others to look at the patency of the palmar arch, or it's not required?
Yeah, initially as a learner, I will advocate that everybody should know to do this test. But now as you grow, you do around 50 or 100 cases, then it's become very easy to do, because sometimes there is an anomalous course of the radial artery, you can go through it, or there is some small branches where it can dissect. So sometimes it is troublesome, but now it is no more an issue once you cross set number of cases.
So ladies and gentlemen, Dr. Tewari bats very strongly for the radial route. It's got a much lesser incidence of complication, can be done as a day care procedure. Virtually all complex angioplasties can be performed by the radial route, and that's the way to move forwards. Thank you very much, Dr. Tewari.
Thank you. Thank you so much, Dr. Yadav.
Pleasure having you.